Today we are going to talk about the pathophysiology of the adrenal gland and the laboratory tests that use to differentiate the origin of the problem. Now, very similarly to the thyroid gland or another gland, we do have a nice feedback regulatory processes here as well. Of course, the major regulatory hormones are the cortisol. So the glucocorticoid is going to regulate the pituitary and further up the hypothalamus. However, as you know that the cortisol level is regulated by, for example, during when we do have an inflammatory reaction by the mononuclear cells, that the cytokines can influence the CRH level, and that further increases that cortisol level. This is why every inflammation, every inflammatory reaction, it will alter the cortisol level and of course consequently the glucose level. If you remember that glucose always higher in inflammatory reaction and insulin resistance can happen. Now, the cortisol is the negative feedback for the pituitary and for the CRH, as I mentioned, and ACTH that is released, ACTH altering not only the cortisol level, but altering the androgen and androgen level and the mineralocorticoid level as well. You know that we do have an additional effect, such as the central adiposity or the visceral adipocytes, that will again be altered by the cortisol. And usually we do have a central obesity if you do have more cortisols. And the leptin level that release out from this adipocyte that negatively inhibit the CRH level. Now, in similarly to the other hormones, the cortisol, the free cortisol is the effective hormone. Now, however, here about 10% is a free form in the circulation, and additionally 75% is bound to the CBG, the corticoid binding globulin, and albumin binds about 15%. Now, this is why the measurement of the cortisol can be taken, the free cortisol measurement can be taken from the urine or can be taken from the saliva, because those secrete or contains only the free form. The mineralocorticoid synthesis or mineralocorticoid regulation is different one. The mineralocorticoid mainly regulated by the renin, angiotensin, aldosterone system. So this is why if we do have any kind of pituitary problem, usually the mineralocorticoid levels are intact because the renin that's synthesized or secreted by the kidney, it can maintain a normal aldosterone release. So in central hypoadrenalism, mostly the mineralocorticoid levels are intact. The mineralocorticoid regulated, such as the blood pressure, blood volume, and the serum and the sodium filtration and beta adrenergic stimulation as well. Directly on the gland, the potassium, increased potassium level, decreased sodium level, and the ACTH also altering the aldosterone release. And the aldosterone is going to affect of the distal tubus and increasing the sodium and bicarbonate reabsorption and the potassium excretion. So the main effect of the aldosterone is increasing the blood volume and increasing the blood pressure. Now, you do like the steroid biosynthesis for sure. Now, here, however, you do not need to learn much more. I don't need the whole enzyme to memorize. One thing is important. 17-hydroxylase, you do remember when we said about the ketosteroids and the 17-hydroxysteroids. So the hydroxysteroids, when we do have a hydroxyl group in this portion, and this is why we do have an increase of the glucocorticoids. If I do not have or we don't have 17-hydroxylase activity, everything going downward, so we do have the aldosterone, so we do have the mineralocorticoid release. And when we do have the ketone group in this position, this is the metabolite of this androgen that is called 17-ketosteroids. So cortisols, the glucocorticoids are the 17-hydroxysteroids, and the ketosteroids are the metabolite of the androgens. Now, additionally, if you do see the vertical enzyme, such as, for example, the 3-beta hydroxydehydrogenase, the isomerase, if you don't have this enzyme, there is no synthesis of the mineralocorticoids or glucocorticoids. There are additionally two enzymes. These two enzymes is very important, especially when we're talking about the adrenal syndrome. Very common one, the classic form that is called the 21 hydroxylase enzyme or 11 beta hydroxylase enzyme. Now, if you do see here, if you are blocking or if you don't have 21 hydroxylase, what will happen? There is no mineralocorticoid action or glucocorticoid action. The previous, such as a pregnenolone or hydroxypregnenolone and androgenesis will increase. So this is what we have, the adrenogenital syndrome. And because we do not have any mineralocorticoid, that is accompanied with hypotension. So there is no mineralocorticoid action. The blood volume will decrease and blood pressure will decrease. But what will happen when we do have an 11 beta hydroxylase deficiency? Well, there is no aldosterone nor cortisol. So because the cortisol missing, the feedback loop is missing. So a lot of ACTH is synthesized. ACTH is going to increase the side cleavage enzyme activity. So a lot of pregnenolone produced. And again, because you cannot go downward, you are going toward the androgen. So again, it will cause adrenogenital syndrome. However, if you're looking at the previous, let's see, metabolite, that's the deoxycorticosterone, this is a DOCA, that has mineralocorticoid action. So in this case, when we do have 11 beta hydroxylase deficiency, we do have an excess of the mineralocorticoid. So this syndrome accompanied with hypertension. So that's be the difference between these two enzyme defect that causes adrenogenital syndrome. Now, how can we evaluate the adrenal gland? First of all, we can determine the concentration of hormones or the metabolite, as we mentioned. However, it's important to know that they do have the diurnal rhythm, and not only diurnal changes, but age and gender difference we do have. Now, the best one to measure the urine and the saliva, because you're measuring the free form directly. This is why in the clinic they're measuring from the saliva. We can determine the basal hormone level, such as aldosterone, cortisol, or dehydroepiandrosterone sulfate, or androstenedione. This test is performed and this test is used. Further, we are going to discuss further possibilities. And of course, CT and MRI is important. MRI mostly in the central nervous system, in the peripheral adrenal gland, usually use the CT test. Now, how can we evaluate the adrenal cortex? First of all, the function. And if you do have a hypofunctioning adrenal gland, what you can use the ACTH stimulatory test. ACTH, it will increase the cortisol release. Or to evaluate the hypothalamic pituitary and adrenal excess, you can use suppression test. This is what we are using in Cushing syndrome. That's a dexamethasone suppression test. Dexamethasone is a cortisol-like material, so it's a glucocorticoid. However, chemically is different from the cortisone. We can apply low and a high dose. Later on, we are going to discuss it. The other test, the stimulatory test, that's a metirapone test. Metirapone is an inhibitor of the 11 beta hydroxylase. So this will inhibit the cortisol synthesis. Because there is no cortisol, we do have an increased ACTH release, and ACTH will induce or increase the activity of the adrenal gland, and the precursors of 11 deoxycorticosteroid level increases, and that's a normal stimulatory test. CRH test can be used as well, or insulin tolerance test. Insulin tolerance test, that's is going to evaluate the function of the hypothalamus and pituitary as well, because the stress from the central nervous system will increase the CRH, and the CRH normally induces the ACTH level, and so on and so on. But as you know, that hypoglycemia will stimulate the growth hormone synthesis as well, not only the ACTH level. Now, what kind of disorders the adrenal cortex has? First of all, we do have a hypofunction, and that's the adrenal insufficiency or primary or the glucocorticoid mineralocorticoid absence. That can be acute or can be chronic. Acute one, when we do have a sudden onset of the destroys of the adrenal gland. This is happening when you do have a meningococci infection and water Hart-Friedrichsen syndrome. So very suddenly the patient, this is the bacterial meningococci, the Waterhouse syndrome, that's the hallmark is a hypotension, hypovolemia, high fever. However, we do have some additional one that's a long-term effect, such as the autoimmune disorders. That is called Addison disease, when the autoantibody destroys the adrenal gland. Now, additional with another third thing that could be more common in Addison disease, the tuberculosis or pseudomonas, for example, or fungal viral infection, but congenital adrenal hyperplasia can be, as I mentioned before, the 21-hydroxylase deficiency, for example, can be cause of the adrenal gland disorders, or 17-hydroxylase deficiency as well. Secondary hypercortisol, secondary cause, when we do have, for example, hypothyroidism, hypopituitarism, not hypopituitarism. That can be, for example, a Sheehan syndrome that is called the postpartum hemorrhage of the pituitary, and radiation, surgery, and acute interruption, prolonged corticosteroid treatment. So this is why you should not stop immediately the glucocorticoid administration if the patient was treated for a long time. You have to decrease gradually. Another thing, the exogenous glucocorticoid administration will decrease the ACTH secretion. So that can be then other type of the secondary hypoadrenalism. Now, clinical presentation of the adrenal insufficiency, basically almost there's not specific sign. The fatigue, weakness, anorexia, loss of appetite, nausea, vomiting, diarrhea, obstipation, abdominal pain, depending on the cause, cutaneous hyperpigmentation can be only the diffuse tan or brown to bronze coloration, and this doesn't occur in secondary insufficiency because the cause of hyperpigmentation is the pro-opiomelanocortin, or the ACTH itself has an MSH effect. So the MSH that is going to stimulate the pigmentation, that could be originated from the pro-opiomelanocortins, the pro-hormone of the ACTH, plus ACTH itself has an MSH sequence in it. So if you do have a very high level of the ACTH, that can color the skin. Orthostatic hypotension due to the hypovolemia, and acute presentation may occur in patients with mild adrenal insufficiency who are stressed in critical illness surgery, mainly attributable to glucocortic deficiency. GFR is going to decrease, hypotension, and relatively is unresponsive to the fluid therapy. Now, let's talk about the hyperfunction. Now, Cushing syndrome, you should memorize. Cushing syndrome is a syndrome, is not a typical or specific disease. We are calling Cushing syndrome when we do have the clinical manifestation of the chronic glucocorticoid excess. We do not know why, but this patient has a very high glucocorticoid level and not an acute increase, but we do have a chronic increase. So you should, what can be the causes? We separate between ACTH-dependent form and ACTH-independent form. ACTH-dependent form means we do have an elevated ACTH level. ACTH-independent form, meaning that we do have a low ACTH level because the ACTH is suppressed by the primary, let's see, hormone level, the target hormone level. That can be, for example, adrenal cortex adenoma or carcinoma, or iatrogenically, when you treat the patient with cortisols or steroids, that can decrease the ACTH level as well, and the patient will develop the typical sign of Cushing syndrome. Now, ACTH-dependent form, when we do have an increased ACTH synthesis, such as, for example, we do have an adenoma of the pituitary. Now, that's a typical specific diseases, and this is called the Cushing diseases. Or we do have an ectopic ACTH syndrome that usually due to the small cell carcinoma of the lung. But this hyperplasia can be due to, for example, CRH overproduction as well. So most commonly, Cushing syndrome caused by pituitary adenoma after ectopic ACTH, and similarly to the peripheral Cushing syndrome, such as adenoma of the adrenal gland. Now, what are the symptoms of the Cushing syndrome? You learn in physiology that central obesity, thin extremities. Why do we have thin extremities? Because the glucocorticoids will stimulate the gluconeogenesis, the proteolysis and gluconeogenesis, and this is why the muscle mass is going to decrease and muscle weakness can occur. Now, moon phase, buffalo hump, or thin skin. Why do we have thin skin and purple striae? Because the cortisol or glucocorticoids inhibit the fibroblast, inhibit the collagen production. This is why subcutaneously the subcutaneous tissues is be very weak and the rupture can happen. Similarly, not only, let's see, the skin is the target for the decreased decreased fibroblastic activity, but the collagen deposition happening in the bone as well. So the bone formation will decrease, and osteoporosis that can be the clinical sign of the patient who has highly elevated glucocorticoids. Retardation in growth usually happening in children. I mentioned muscle weakness can occur, muscle atrophy we discussed previously. Infection can occur because they are suppressing the immune system. Mental problem, depression can occur, hypertension can occur because the cortisol has a permissive effect on the catecholamine receptors, diabetes mellitus because it antagonizes insulin effect, hypokalemia can happen if you have a high sodium retention and potassium excretion together with the alkalosis mostly, and nephrolithiasis is due to the bone resorption and excretion of the calcium into the urine. Now, when we should think about the glucocorticoid excess, first of all, if somebody has diabetes mellitus or hypertension, that doesn't respond to the therapy. In children, when the growth retardation occurs, or idiopathic osteoporosis in men, or excellently, we discover some kind of tumor in the adrenal gland, that we should suspicious about the glucocorticoid excess. Now, how we are going to evaluate the patient who has Cushing syndrome? First of all, mostly what they do, they measuring the saliva, the night saliva cortisol level. This is what they're doing today. After they are giving the low dose of dexamethasone. This low dose of dexamethasone is good to differentiate between Cushing syndrome or no Cushing syndrome, because the clinical symptoms of the elevated Cushing syndrome can mimic some additional endocrine disorders such as a polycystic ovarian syndrome and additionally. Now, if we do have let's see, an inhibition of the cortisol release by dexamethasone, for sure the patient does not have Cushing syndrome. We have to look something else. However, if there is no suppression by this low dose of dexamethasone, we go to the next step. We should check the ACTH level. Now, ACTH level, depending on the origin of the problem, if we do have an adrenal origin, that is called a primary problem, that the ACTH should be low because the synthesized cortisol level inhibits the ACTH level, and this is why we do have a ACTH independent form. However, if we do have an elevated ACTH level, that can be hypophyseal, or that's called Cushing disease, or it can be ectopic ACTH syndrome. Now, how can we differentiate between the hypophyseal and the ectopic ACTH overproduction? Now, here we use the high dose of dexamethasone. The high dose of dexamethasone, it will inhibit only the pituitary adenoma, the pituitary ACTH level, but the ectopic one is not. So if you do have a suppression that more than 50%, that's showing that that's a hypophyseal origin. If not, that's an ectopic one. Now, CRH test usually can be used if you are not for sure or they didn't respond well. So they should measuring the ACTH level. So they're giving CRH, and if the ACTH level increases, that's again showing that this patient has Cushing disease. However, if it's no elevation, that possibly is an ectopic origin. In very rare case, they are using this sinus petrosus inferior cannulation, and this is how they can measure, let's see, the response to the CRH test. Imaging techniques for cellular MRI or adrenal CT should be performed. Now, this diagnostic algorithm in summarizes what I mentioned. First of all, you are measuring the free cortisol level, and you are giving 1 milligram or low dose dexamethasone. If it's suppression, okay, that is not Cushing syndrome. If it's not, possible Cushing syndrome. Next one, high dose and measure the ACTH level. If the ACTH is low and no suppression, that possible that's an adrenal Cushing syndrome. Take adrenal CT and adrenalectomy could be the treatment. Okay, if you do have let's see, normally to very high ACTH, a lack of suppression, that possible is an ectopic ACTH syndrome, chest CT, abdominal CT, and surgical removal of the ectopic source. If we do have, let's see, a normal to elevated ACTH and suppression, the ACTH is suppressed, that's a Cushing syndrome, MRI, okay. If you cannot see if the suppression is normal or not, after you can use the CRH stimulation test and cannulate the inferior petrosus sinus sampling, and that you can decide whether there's a pituitary or Cushing. Sometimes you do not see the tumor nor in the pituitary nor in the ectopic sources. Let's see a case to understand this. We do have a 68-year-old woman, non-hypertension for 10 years. So she's hypertensive for 10 years. A few months ago, she noticed her face puffed up, so the moon face, meteorism, and knee swelling. Furthermore, she's complaining about weakness of limbs and blurring of vision. Blurring of vision could be the tumor of the pituitary. So this is a bitemporal hemianopsia could be. She gained also 2 to 3 kilograms lately. Very importantly, if somebody is gaining weight shortly, that could be some kind of endocrine disorder, such as a Cushing syndrome or hypothyroidism. And which she could not lose, physical state, central obesity, moon face. Laboratory tests showed an elevated serum cortisol, elevated ACTH level, and the collected urine cortisol elevated. No hemianopsia was found in ophthalmologist, and hypophysis adenoma was proven by the MRI, so that's a Cushing disease. Now, this is how the normal head CT or MRI looks like, the MRI. And here you can see that this is a teeny tiny small one, 5 millimeter adenoma. So that's a microadenoma shown by the arrows. This is what we could see it here. And the diagnosis, there's a Cushing diseases. They're performing some surgical removal, transsphenoidal surgical removal of the tumor. And after they have to substitute the patient with those hormones that they lost. Next one, a 17-year-old woman, known hypertension for 3 years and diabetes mellitus type 2, present administration was due to the disturbance in her carbohydrate metabolism. CT was performed because she had atypical abdominal pain, and the tumor was found in the right adrenal area here. So that is a incidentaloma in this case, but the patient has a problem with the glucose level. So they checked the hormone profile. They found that the cortisol level increased, and overnight cortisol in saliva increased. In the morning is still high. So usually if somebody has a problem with the cortisol metabolism, let's say the central or the peripheral one, the first one, the diurnal rhythm disappears. In the morning, normally in the morning, we have the highest one, and that's going to decrease by the night. Now, if you don't have this diurnal rhythm, if it stays the high, that's be the first sign of the Cushing syndrome. The low-dose dexamethasone test, no significant suppression. ACTH was very low. So yes, it's proved that this patient had an adrenal adenoma, or that's a peripheral Cushing syndrome, and the therapy is a surgical removal of the tumor. Now, let's talk about when we do have more mineralocorticoids, not the glucocorticoids, but mineralocorticoids. If we do have a primary hyperaldosteronism, meaning that the gland itself secretes more aldosterone, this is what is called Cone syndrome. So the etiology of the Cone syndrome can be a tumor, adenoma, the aldosterone producing adenoma, or carcinomas, hyperplasias that usually occur some enzyme abnormality. Deoxycorticosterone excess can be due to 11 beta hydroxylase deficiency. Okay, for example, the mistletoe T, this little alkaloid, can inhibit the 11 beta hydroxylase. In case of 17 alpha hydroxylase deficiency, not only the deoxycorticosterone, but aldosterone level increases. If you do remember what we had in the first slide, when I explained you the steroid hormone synthesis, you do see that this is going to inhibit the synthesis of the cortisol and the gonadal steroids. And everything goes downward to the aldosterone release. Now, what will be the clinical features of this Cone syndrome? Hypertension, whatever is marked red, these are the important ones. Hypokalemia, possible, and metabolic alkalosis, and non-specific, such as the muscle weakness and polyuria and polydipsia. These can be the clinical symptoms. Now, secondary hyperaldosteronism, that meaning that we do have an increased aldosterone level, but this is not due to the production of the aldosterone itself, but somehow this production is induced by something else. Now, there are two things we do have with hypertension or without hypertension. Why is it important? If we do have a normal blood volume, and if we do have an somehow increased aldosterone release, that will cause hypertension. However, if the aldosterone release was due to hypovolemia, that doesn't cause hypertension because it wants to normalize the blood pressure. Let's start with without hypertension. For example, sodium wasting syndrome, when the kidney losing, for example, sodium, or when we do have an adenomatosis state, we do have a redistribution, and this is what decreases the blood volume, and such as happening in cirrhosis or nephrosis or renal tubular acidosis or potassium losing kidney or congestive heart failure. So in case of adenoma, or not adenoma, edema, in edema we do have a decreased blood volume. The decreased blood volume will stimulate the renin, angiotensin, aldosterone system. So this is why we do have an elevated aldosterone, but this aldosterone wants to normalize the pressure. Now, additionally, in cirrhosis, not only the hypovolemia, but the steroid metabolism is altered because the liver will metabolize or catabolize the aldosterone, and because it doesn't work, so this additionally will increase the aldosterone level. Now let's let's see what happens when we do have a normal volemia. A lot of cases in renovascular diseases, when we do have an atherosclerosis of the artery renalis or stenosis, that meaning we do have less GFR, less sodium filtrated in the macula densa, that will increase the renin secretion, aldosterone secretion. Or we do have a tumor that rises and from the renin secreting cells, and again that can cause hypertension. In accelerated hypertension, when usually the afferent arteries are affected in the glomeruli, again that can cause hyperaldosteronism. Estrogen therapy will cause hyperaldosteronism. Or nephropathy in pregnancy, again that can be accompanied with primary or hypertension and secondary hyperaldosteronism. Now, what shall we screen for mineralocorticoid excess? When we should do it? Relatively when the patient has hypertension and one of the following symptoms: hypokalemia, severe resistance or relatively acute hypertension, or adrenal incidentaloma. In this case, we should evaluate the mineralocorticoids. Now, how do we do this one? First of all, we're measuring the aldosterone level in the serum. Next one, we're measuring the ratio of the aldosterone over the renin. There are three possibilities. If we do have an increased renin activity plus increased aldosterone, the ratio should be less than 10. That could be the secondary mineralocorticoid excess. If we do have a low renin level but increased aldosterone, the ratio is higher than 20. That means the primary problem. If both decreases, that's a mineralocorticoid excess, but it's not due to aldosterone. Possible that can be deoxycorticosterone, for example, or enzyme defect causes this one. Adrenal vein sampling, that's a gold standard to measuring the renin and aldosterone level, and CT imaging should be performed to see whether we do have some kind of narrowing of the arteries or not, or the tumors and everything. Now, laboratory evaluation for this one, hyperaldosterone is the secondary one. Salt loading, that usually they're taking IV or paras. That's sodium intake normally decreases aldosterone and renin level. That's another drug, for example, it's a mineralocorticoid mimetic or mineralocorticoid agonist. That's a fludrocortisone. That's a suppression test because normally should decrease the mineralocorticoids. That be very similar to the test that you applied in Cushing syndrome. That's a but they are using for the mineralocorticoid. So it's not the dexamethasone, but similarly to the dexamethasone, that fludrocortisone, that's a mineralocorticoid hormone. Or captopril test. Captopril is an ACE inhibitor. That's again, this ACE inhibitor normally decreases the hormone level. Okay, this patient case study is that if you have a 57-year-old woman and treated hypertension for 5 years, She complains about progressive fatigue and weakness for 1 to 2 weeks. Sometimes without any effort, she feels tenacious chest pain together with the dyspnea, but ends spontaneously. She has palpitation occasionally, and look at the status. The blood pressure, it's elevated, pulse is okay, serum sodium is okay, however, the potassium concentration is lower one, and the patient has ventricular premature beat, as you do see here, okay? And this after normalizing ions, ECG becomes normal as well, so that's due to the hypokalemia. They measure the aldosterone level, it was very high, and there was no effect by the salt, so no decrease by the salt loading. Renin activity is low, it's almost undetectable after salt loading, and they did, let's see, the CT of the abdominal CT, and they found a tumor in the adrenal gland. So that is a adrenal adenoma. That's a Cushing syndrome. You should remove, let's see, the gland. Now, adrenogenital syndrome. What adrenogenital syndrome means? It's meaning that because we do not have normal cortisol synthesis, if you do remember the first graph, that everything, every hormone synthesis shift toward the androgen synthesis. The most common one is a 21 hydroxylase deficiency, and as I mentioned before, this will cause hypotension because we do not have mineralocorticoid nor glucocorticoid. The incidence is relatively very rare, 1 out of 10,000 births. That's heredited, autosomal recessively heredited. It is the age-early linked diseases. Usually it's linked to the age-early A3 or BW47 or DR7. That meaning all the autoimmunity. That's it. Excess sex steroids cause virilization and hirsutism. Virilization means the secondary male features on girls, and hirsutism means only that extra hair grow on the testosterone-depending areas. Premature adrenal and infertility can happen, and because no aldosterone, this is why the salt losing crisis can happen. A hyperkalemia and hypotension can occur in this patient. Now, this is the graph, as I mentioned. So we do have an increase of the precursors, and everything shifted toward the sex steroids. And this is what they are measuring. So in that case, we do have an elevation of the precursors, and that's the direct proof of the 21 hydroxylase deficiency, but usually is associated with hypotension, not only the increase of the androgen level, but decrease of the blood pressure because we do have less mineralocorticoid effect. Now, the second type, that's a 11 beta hydroxylase deficiency. That's a not classical one. It's very rare, as you see here, 2 out of 200,000 live birth. And that's an autosomally and X-linked chromosome disorders and excess sex steroids, virilization, hirsutism, premature adrenal infertility, very similar. However, no aldosterone, but we do have a very high deoxycorticosterol level, which is an antagonist of the MC receptors. So hypertension and hypokalemia can happen. Now, this is what with the graph, the precursors elevated. So this is why we do have a lot of androgens, but we do have deoxycorticosterone, and this is how they can figure out that this is 11 beta hydroxylase deficiency. Now, adrenal medulla disorder, the hypofunction, and when the patient usually receives glucocorticoid replacement therapy, and following after, this is how they did it. And orthostatic hypotension is a very characteristic sign. So that's a medulla. Medulla usually synthesized catecholamines. Now, a hypofunction relatively is very rare situation and only can be manifested as an orthostatic hypotension. If somebody receiving glucocorticoid replacement therapy, for sure, or they're removing, yes, you can have a hypofunction, but they are not influencing too much the blood pressure. Usually the hypotension can occur in this patient. Hyperfunction is not a common disease, relatively it's a rare disease when we do have an excess of the hormone that is synthesized by the adrenal medulla. This is a part of the sympathetic system. So this kind of tumor that rises from acromaffin cells, they will stimulate, let's see, the system by increased sympathetic activation happening. Now, what will be the clinical sign of Theochromocytoma? If we do have, let's see, the attack, usually this attack is happening in paroxysmal. The patient has a very high blood pressure, headache, sweating, palpitation, tremor, paleness, nausea, vomiting, and be very aggressive. In between attacks, usually the patient has cold hands and feet, meaning that we do have a peripheral vasoconstriction, weight loss, orthostatic hypotension can happen, and fatigue, and usually the patient is anxious and panic. Now, what kind of diagnostic test we can use? We can measure the hormones. However, it's only one problem, that the epinephrine, norepinephrine level is fluctuating and they don't have a long, steady state. So what they do, they're measuring the metabolite. Usually they're measuring the metanephrine and normetanephrine level. In the serine, we can measure the chromogranin A, that's a tumor marker. And this is a member of the secretogranin family, secreted in adrenal medulla, and in the GI tract, in the pancreas endocrine cells, so that is used as a tumor marker. A clonidine suppression test that usually blocks the alpha receptors. That's a catecholamine-like effect, decrease catecholamine production normally, and a strict in the morning should perform. Now, imaging technique, ultrasound, MRI, CT, and we do have an additional one that's called MIBG uptake. This is a radioactive material that is going to be incorporated by the chromaffin cells. And in those cases, when the Theochromocytoma, so this tumor is not rise from the medulla, but rise from the paraganglionary system, you can figure out the presence of this tumor. Now, this, for example, imaging technique, in CT, you can see this, especially in both the medulla, CT scan, and this MIBG scan that the methylbenzoate, well, it's showing that accumulates in the adrenal medulla. This MIBG should be remembered, so it looks like it's a man in black G. So whatever you like to use to remember these things. Okay, let's see a case study. 29-year-old woman with non-untreated Basedow's syndrome and hypertension. So the grade Basedow's, so the hypertensive one, she suffers from attack of palpitation, tachycardia, sweating, and turning pale for 2 years more and more often. And they measured, let's see, they collected urine, the norepinephrine was very high, epinephrine level, dopamine level, metanephrine, normetanephrine, and chromogranin A level, the tumor marker was very high. So, and the C and MRI that they performed and showed a tumor of the adrenal area. So this is the Theochromocytoma, and the treatment, usually the surgical removal of this tumor.